It won't take long.
I request
right.
everybody to mute themselves. I think you give the countdown, Sham.
Yes, ma'am. 5, 4, 3, 2, 1. We are live, guys.
Good evening. A warm welcome to all who have taken great efforts to join us in this evening from all over the world. Welcoming you all to the WIN Global panel discussion on guidelines and practice patterns for optimal kidney care challenges and solutions. As part of the World Kidney Day 2024 celebration, WIN India has orchestrated Penta Day activities that began yesterday and today marks the second day. This evening is truly unique, bringing together distinguished women nephrologists, the experts in nephrology from around the world on a single platform to discuss global kidney services and challenges. As we all know, this year's World Kidney Day theme is Kidney Health for All, Advancing Equitable Access to Care and Optimal Medication Practice. The theme aims to raise awareness of inequalities in kidney disease treatment and encourage collaborative efforts to improve access to appropriate treatment. A collaborative effort is the need of the hour, and today's program serves as a perfect example. Today, WIN India is conducting this panel discussion in collaboration with WIN Europe, WIN Latin America, WIN Africa, WIN Caribbean, and we have eminent women nephrologists from various countries around the world, including Jamaica, South Africa, Switzerland, Brazil, Peru, France, and our own country. And once again, I welcome you all to the global panel discussion. And as moderators of this discussion, we have Dr. Arpita Rai Chowdhury, Professor and Head, Department of Nephrology, NBMCH Kolkata, and she is the President of Indian Society of Transplantation. We also have Dr. Manjusha Yadla, Secretary of WIN India, Professor and Head, Gandhi Medical College, Department of Nephrology, Hyderabad. I request the moderators to take over the session. Over to the moderators.
Dr. Arpita, ma'am, can you just unmute yourself and start the introduction of
Sorry.
speakers? Yes, ma'am.
So a very good morning, afternoon, and evening to everybody. So Jyoti has perfectly launched the World Kidney Day slogan and set the platform. We all know we have lot of recent medical advances which has significantly slowed CKD progression and reduced complications. And we know that diabetes, hypertension, and obesity are three lifestyle diseases which had really pushed the CKD population globally to the statistics of 1 in 10. So this webinar is planned to increase the awareness of different parts, to improve our advocacy for our own land. And we start with Dr. Valerie's introduction. Dr. Valerie is worldwide known nephrologist with interest in public and global health and ethics. She is based in Switzerland, but originally from South Africa. She is well versed with the both sides of the coin. And I would take the privilege to introduce my good friend, Professor Manisha Shahai, who is also well known nationally and internationally as a very high grade academician. Now, along with many other responsibilities, is observing the responsibility of Vice President of WIN India. And Dr. Raquel Jones, she's ISN Fellow, Crook Fellow alumni, and she's also a consultant physician and nephrologist in Mandeville Regional Hospital, Jamaica. Welcome, Raquel, to our webinar. And then I take the privilege of introducing one young star who is an ISN fellow from India only. She worked in PGIMR. She's an emerging leader, consultant nephrologist in a teaching hospital in the University of Nigeria. So welcome, Ugochi, to our webinar. And I would like to ask Manjusha to introduce the other three panelists in our webinar. Manjusha,
Thank
please.
you. Thank you so much, madam. It's lovely to see everyone on the platform. It's really encouraging that we have the global women nephrologists joining us today to discuss the pertinent topic in relevance to the World Kidney Day of 2024. So may I take this opportunity to welcome my good friends, Dr. Vivian, who is a nephrologist from ProRim Foundation, School of Medicine, Unival, Brazil. She belongs to ISN ELP cohort 2021. Vivian, I hope you're doing well. Vivian, how are you? I hope you're good, Vivian. So moving on.
Yeah, I'm very good and very happy to be here with
Great,
you all.
great to see
Thanks
you.
for the
Great to see you
opportunity.
and great to have you on this platform, Vivian.
Thank you.
We have another friend of ours, Dr. Ana Cecilia Pasteludena, who is a nephrologist consultant, who is also an active member of International Society of Nephrology, joining us from Peru, South America. How are you, Inez? How are you doing?
Hello, how are you, everyone?
Great, nice to see you. I'm glad to have you on board. We have Dr.
Thank you.
Urmila Madam, who is the driver and, of course, the steering person of the whole Women in Nephrology India. She is the president of Win India. She's presently in Switzerland exploring the opportunities of expansion of the transplant field, joining along with Dr. Valerie with us. So welcome, madam. Welcome everyone on board. And in a short while, without much ado, I think Dr. Arpita, madam, we can start posing our questions to our beloved panelists. Over to you, Dr. Arpita, madam.
So first question goes to Dr. Valerie. Dr. Valerie, are you there? Yeah.
Yes.
Yeah. So CKD is pandemic and it is on board. How do you address the need for raising awareness in general, particularly to the disadvantaged population about the risk factors of diabetes, hypertension, obesity, the basic things they need? And I would also be happy to ask you that how far you are able to take into our fraternity the increase of use of ARB and SGLT2I as renoprotective medication.
Okay, well, thank you very much for inviting me to participate and, be part of this wonderful week, I guess, World Kidney Week. I think you asked very, very difficult questions. How do we raise awareness about kidney disease? And I think it has to happen at multiple different levels. I think through the ISN, we're trying to raise awareness through the WHO, because I think unless there is sort of awareness at the government level, it's very difficult that practical changes will actually happen, trickling down through the health system. I think in terms of raising awareness on that level, we are trying to highlight, the burden of kidney disease. And there, unfortunately, we don't have that much data. A lot of the data that we constantly are quoting is actually extrapolated from what we think is, the CKD numbers. If we say in a certain country there's X population and we assume maybe 10% of the population has CKD. So I think all of us should really be contributing to try to improve data so that we really know numbers of people with kidney disease. We need to understand risk factors, and then we need to understand what's happening to those patients. Do they have access to care and the spectrum of care, from prevention of risk factors all the way through to dialysis or transplants or even palliative sort of supportive care. I think in terms of raising awareness amongst the disadvantaged populations themselves, some of our colleagues are actually doing amazing work. There's a gentleman called Elliot Tanor who's in Ghana, and he has started a screening program in Ghana, and they literally go with a bus to various communities. We were just discussing whether he could actually start doing that in some of the refugee communities, where really the most disadvantaged people are with the least access to care. The biggest problem there is that people like him, and I'm sure a lot of other people are doing that also in India, are going to communities, trying to educate communities, having sort of town hall meetings, talking about risk factors, obesity, lifestyle, getting their blood pressures checked, getting their blood sugars checked, those kind of things, making sure that they actually are on the right medicine, that they take their medicine regularly, reduce their risk, control their risk factors. But the huge challenge is the cost of the creatinine test. I know once Manjusha had mentioned to me that it was, the cost was not too bad. I think in Telangana, you said, But in Africa, for example, if people have to pay out of pocket, it can be quite expensive. And I think Ugochi can maybe mention the cost. So, I think making people aware of the risk factors is important. I think also for patients or for the general community, making them understand that the risk factors for kidney disease, heart disease, diabetes, hypertension, strokes, all these things are the same risk factors, so that we don't overwhelm people with information. We just tell them very simple messages that look after their entire cardiovascular system, which includes the kidneys. Because I think simple messages are much more likely to get through than difficult ones. And then I think if we move over to the clinicians, because you were asking, how do we improve the actual use of the medications? And this was one of the things that we wrote in the editorial for World Kidney Day. Very surprised. It's kind of disappointing that only 20%, so about half of the people living with hypertension have a diagnosis. And of those with a diagnosis of hypertension, only 20% are being treated to a blood pressure below 140/90. And this comes from the World Hypertension Report that was published last year. And then in diabetes, they think that around 60% of people living with diabetes have a diagnosis, and only 60% of those have a hemoglobin A1C below 8%. What we know about chronic kidney disease, 10 to 20% of people are aware. And there as well, between 20 and 60% of people are reaching various targets, on an ACE inhibitor, 5% are on SGLT2 inhibitors. So really not enough. And there we need to work on our primary care colleagues and our nephrology colleagues to try to make sure that they understand the importance of these medications. But also, I think we should not confuse people again with about 10 different guidelines. I feel we should probably coalesce the guidelines and have sort of cardiovascular guidelines looking after kidneys, heart, diabetes, hypertension, strokes, everything all in one guideline, so that the doctors are also not overwhelmed. Because there was one study that I read from North America that if a single family doctor was to follow a guideline for every patient that they saw in their practice, they would need 27 hours a day to deliver guideline appropriate care. So I think we need to be sure not to overwhelm our colleagues with instructions, not to overwhelm the patients with messaging, and we need to make sure we have good data so that the policymakers understand that they need to include kidney disease in their primary care programs. Thank you.
Very nice answers, Valerie, and very pertinent. Particularly, I feel that the primary care physicians feel threatened whenever there is a bit of permissive AKI after using ACE-ARB and SGLT2I. I have also observed that when they started two together, probably the magnitude of the hemodynamic AKI went little beyond the expected, and there is a real true hiccup about it, that whether we should use, and there is a fear rather than comfort of using. So these small clues we may try to take to them, that don't start probably simultaneously, look at the response to one agent and then go to another, and with a few weeks gap, that would be more appropriate. Thank you. We may move to Manisha for the second question. Manisha, I can see you in the frame. Are you there?
Yeah, I'm there.
Yeah, you are there. Manisha is a great worker. She's a very good academician as well as first-hand worker. So in a developing country like us, we are experiencing a transitional epidemiology, a malnutrition and overnutrition together, a too rich population and a too poor population. Similarly, diseases are distributed in that way. And across the country, there is a lot of regional variation. So climate changes, the diseases change. You are a public sector professional and highly involved in the strategic planning of your state's kidney care. What you are doing in your state, particularly for the low socioeconomic group, which people can replicate in their population.
Okay, so thank you, Valerie, and it's thank you, Arpita. It's an honor to be here and speaking after Valerie. Valerie has made very good points. So I'll speak in context of our country and our state. So India, we all know, is an LMIC country, and we are a hugely populated country. We have 1,400 million people, which is 3 times as common as US. So it's I mean, a hugely populated country, and we have so many divisions in the country. We have 29 states, so many union territories. So we have, India is a country with many countries within itself, and each state is different. The language is different, the religion is different, the economies are different, the schemes are different. And then we have a government at the center. So there are certain schemes which are applicable all over the country, and there are certain schemes which are applicable to a particular state. So now these are some of the things we have. And important thing is the central scheme now covers the dialysis for almost all the country. It's called Ayushman scheme, which covers dialysis, where dialysis centers are available in 700 plus districts of India, in each and every state of India. So these are some of the pluses we have. But what are the problems now? The problems are states are different. Each state has its own regional problems as well. For instance, I belong to a state of Telangana. Telangana is the youngest state in India. Now we have a state dialysis scheme. We have 30 plus districts in Telangana. Many of these are urban, others, almost 70% are rural. We have a scheme called Arogyashri, which is penetrating throughout Telangana. The positive point is it covers dialysis of the underprivileged population of Telangana. Each district has a dialysis center. So this is something called hub and spoke model of dialysis. So remember, in our country, we have very few nephrologists and we have a lot of patients. In India itself, we have 2,500 nephrologists and we have, 1,400 million patients to look after. Out of that, almost 20% have CKD. Physicians' workforce is around 7 lakhs. So in India, nephrologists cannot take care of the problems of CKD, cannot man the dialysis centers. So how are we addressing this problem in our state, where you have people sitting in the cities, majority of the nephrologists in the cities? So the unique model which Telangana has adopted is hub and spoke model. So one of the important things is hub and spoke model means the hub center lies in the city and it has around 20 to 30 spoke centers under it. So the nephrologist sitting at the hub center coordinates at the local doctor available at the spoke center, who need not be a nephrologist. And that way, the medical care is able to reach the grassroots level. So this hub and spoke model unfortunately exists as of now only for dialysis. Dialysis is end-stage kidney disease treatment. What we need is prevention as well. So we need a hub and spoke model for preventive care services, because we can treat patients who already have end-stage, we can offer dialysis, we can do transplant. But what we are not focusing on right now is the preventive model. And we already have this hub and spoke model in place. It does not need extra personnel. You already have a dialysis unit there. You just need a table beside that dialysis unit where the patients come with the attendants. The attendants can be screened. That work can begin from the family itself. The high risk groups can be screened. So the same hub and spoke model, the doctor sitting at the hub can man the spoke centers as well, reaching the grassroots level. These centers can also provide opportunity for teaching and training of the general practitioners who are not necessarily nephrologists, who are looking after the people at grassroots level. Because what challenges we face, that in international society is making so many guidelines, Indian society is making so many guidelines. Finally, these guidelines are getting disseminated to the nephrologist. But by the time the patient is reaching us, nephrologists sitting in the urban areas, the patient is already in end-stage kidney disease, either stage 4 or stage 5. Stage 1, 2, 3 are completely missed. So who should tackle these stages? Not the nephrologists, the GPs. Whatever specialty they are in, they should be made aware of the 10 commandments. Nothing, no theory, no molecular research, just 10 commandments. Glycemic control, BP control, use of ACE and ARBs, use of SGLT2 inhibitors. Now you have GLP-1 as well as finerenone. So cost is there, I do understand. But are we teaching them to maintain the blood sugar? No. Valerie rightly pointed out how many have a hemoglobin below 8% HbA1c. Below 8%. In fact, in India, pre-diabetes also is existing. So what I feel, the challenges, what we are facing is we are aware of the guidelines. The nephrologists are all educated. The ISN knowledge has gone to all the nephrologists. But the problem is that we should focus the people who are treating the patients at the grassroots level. we should train them about the 10 commandments, the simple commandments which they should follow so that we are able to arrest the progression to end-stage kidney disease. So what we are trying to do at our level in our hospital is utilize these hub and spoke centers to impart teaching about primary prevention of CKD, running a preventive care clinic next to these dialysis centers, and also running a kidney supportive care service. That dialysis may not be for everybody, and
Yeah,
many
ma'am.
of them can
Yeah.
be supported with this kidney supportive care. So that's how we are trying to run this hub and spoke model, not only for dialysis, but for preventive care nephrology as well.
Great
Having
insight,
said-
Manisha. Thank you.
Yes.
And we would
Thank you.
move to Dr. Raquel. Yeah. We would move to Dr. Raquel from Jamaica. Hi, Dr. Raquel. You are there?
Hi, good
Yeah,
afternoon,
yeah, yeah.
morning,
So,
good evening.
good afternoon, Raquel. So we need to know something about the healthcare systems in place for kidney care in Jamaica. How are you giving the kidney care to your patients? Do you run by government sector only, like UK, or there are many private dialysis sectors run by nephrologists or non-nephrologists? What do you think? This is better change in kidney practice patterns?
Thank you for the question. And I want to thank the organizers of the Women in Nephrology India chapter for inviting me and to be a part of this distinguished.
Hello?
Can you hear me?
Yeah, Raquel, please go ahead. Yes, you're clear.
Okay, okay,
Yeah,
great.
yeah.
So though I'm from Jamaica, we have to consider kidney care in Jamaica as part of a bigger region, which is the Caribbean. Now, Jamaica is a small country. It's in the Caribbean, and it's one of
Sorry,
the,
Raquel, we can't hear you.
No, Madam Raquel is audible.
oh, okay.
Yeah.
So it's it's the biggest English-speaking country in the Caribbean of about 2.9 million people. And kidney care is really broken down into public and private sectors. Now, Jamaica, we know it's known for the music, the reggae, the culture, the food. However, all of this plays a role in persons with kidney disease. Most of the population, we don't even have an exact incidence of kidney disease in Jamaica, but within the region, we know that it's higher than the global population, as well as death is much higher as well within the region. For Jamaica specifically, however, many of our patients who suffer from CKD in the nephrology clinics within our government health centers or privately through the nephrologists within Jamaica. And there's about 10 of us in Jamaica right now. We definitely need the capacity to increase the amount of practicing nephrologists and those who want to pursue nephrology. Now, the thing with
Excuse me, Raquel. Can you hear me?
I can hear you quite well.
We can't hear you.
We can hear, Madam. Raquel is audible, Madam.
Arpita, we can all hear her. I think you cannot hear. We can all hear
Yeah, I
her.
can hear her.
Yeah,
Right.
Raquel,
I can
please go
hear
ahead.
her.
Yes, Raquel,
You
you're
can-
clear. Please go ahead, Raquel.
Okay, great. So what we find with our kidney care in Jamaica is that we're not catching patients early enough. They present very late. They present with advanced kidney disease very late. And unfortunately, at that time, our hands are tied with just offering renal replacement therapy. We have 3 to 4 government hospitals that provide hemodialysis. And unfortunately, I would like to say unfortunately, that most of the renal replacement therapy in Jamaica is done via hemodialysis. The uptake of peritoneal dialysis is not there. It's not promoted as much. And there are several factors for that. But unfortunately, when the patient do present to us, it's quite late, and that's what we have to offer. Sometimes we don't have time to, offer investigations to see why they went into renal failure. And what we find is, even younger persons are presenting with quite advanced stage kidney disease. And that uptick was also seen after the COVID pandemic, where many persons were presenting with nephrotic range proteinuria, and so needed further investigations and biopsies. Now, biopsies, unfortunately, is a cost to the patient, and everything within Jamaica, there's a cost. Although our healthcare is government subsidized and it's quote unquote free in the government system, the amount of resources available is not there to absorb the amount of persons that present with kidney disease. And so we find that many of them are left with not adequate care because we don't have the resources to include everyone. The public clinic appointments are very long, months. Supportive medications is given through the government, basic medications. We have a national health fund, which actually does not include chronic kidney disease, which is a big concern. So if our national health fund doesn't include chronic kidney disease, many of our patients will not benefit from those resources in terms of life-preserving and life-sustaining medications. So, it's resources it's a big issue. We are part of the lower middle income bracket. And so, it becomes very difficult sometimes to explain to a patient that, you need a spot urine albumin creatinine ratio and you have to pay for it. It's not offered. Our basic screening that's not offered through the public system, and patients have to pay for it. So it's very difficult.
Great answer, Raquel. Actually, it echoes the Indian situation as well. We CKDs reach late, and we face the similar problems like you that was spoken by Manisha as well. And this involvement of the government sector till few years back was not so intense in Indian field as well. As you were speaking, that government is interested, but there is not always resources. So with that, we may go again to Ugochi. Ugochi, are you there? So we will be talking about another area of CKD prevention, that is stop AKI. We know that is a mandate to decrease the progression to CKD. Is there any notable change in AKI trend in LMICs like your country? I'd like to speak to Ugochi. Ugochi is there?
Yes, I'm here.
Yeah.
So, good evening,
Ugochi,
everyone.
please.
I'm so glad to be.
It's good. All good, Ugochi? It's all good?
Can you?
Okay.
Yes,
okay.
good. Can you hear
So
me?
is there any notable change in AKI trend in LMICs like your country, especially as it concerns women?
So it's well recognized that AKI is a risk factor for development of CKD and also progression of existing one. And for Nigeria, with being the most populous country in Africa, I think it's good for us to be a case study for this. Now, unfortunately, just like Valerie has mentioned, paucity of death. However, can you still hear me?
Yeah.
Okay.
We can hear
So,
you.
however, we have a data that shows that in hospital admissions, up to 22.3% of patients have AKI. And this value is even worse in ICU, which goes up to 58.9%. And among the women who are pregnant, AKI occurs in 6 to 38.8% of them. And overall, the mean age of patients who have AKI in Nigeria was put at 41 years. That represents the active or the labor force of the country. Now, for trend in AKI, there hasn't really been any change because community-acquired AKI still remains the commonest presentation of AKI, accounting for 70 to 90% of cases. And out of this, 20 to 40% of cases come because of sepsis. So sepsis still remains the commonest cause of AKI. And as it regards women, obstetric cases contribute 5 to 27% of cases of AKI. Now, for the Stop AKI, which is ACAN, to the ISN 0 by 25 initiative, which looks at screening and treatment of sepsis, avoidance of toxins, optimization of blood pressure and volume status, and then prevention of harm by treating the cause of AKI, its complications, and of course, making sure that drugs and fluid prescribed are adequate. Now, in Nigeria, we look at infections. Malaria used to be a very big problem for us, but that is mainly for the pediatric population and, of course, women who are pregnant. However, with the wide availability of drugs and treated mosquito nets, as well as the new vaccine that was introduced, we believe that very soon we'll be able to conquer malaria. However, we have other things that worry us. For instance, in 2018, we rejoiced that the prevalence of HIV infection had dropped to 1.4%. But the figures are going up now. For women who are between 15 to 64 years of age, prevalence is about 1.9%, and it's projected to increase because as the economic situation begins to get worse than it is feared that some women might opt for commercial sex work as a means of livelihood. And currently, among the commercial sex workers, the prevalence of HIV alone is 16.7%. Other bacterial infections are also prominent as causes of AKI. Unfortunately, in recent times, many multinational pharmaceutical companies have left Nigeria because of unfavorable market, and this has made the cost of antibiotics to skyrocket up to 5 or even 10 times its cost. Therefore, if a patient presents with sepsis, AKI from sepsis, treatment becomes difficult because patients will not be able to afford their antibiotics. Now, the other point that is also important is nephrotoxins as a cause of AKI. Just like what you see in other developing world, the use of herbal concoction is quite on increase in Nigeria. And we as nephrologists are even more worried that it's going to increase more. As the cost of care increases, drugs are unavailable and unaffordable. Many patients are likely going to resort to the use of herbal concoction. And we know what this is going to do in the prevalence of AKI. For women especially, obstetric causes we mentioned is still high as a cause of AKI, and that hasn't changed much. And we are also being worried now that cost of care is increasing, cost of transmission is increasing. Many women are going to opt out of antenatal care, and they are going to resort to giving birth in traditional birth attendance homes, maternity homes, and not in standard care. And this will increase their possibility of having acute kidney injury. So what do we do? In Nigeria, the Nigerian Association of Nephrology is doing a lot of advocacy to try to draw the attention of government to AKI and other kidney diseases. So far, we have been able to achieve inclusion of 6 sessions of hemodialysis for AKI patients in the National Health Insurance Scheme. This is actually so small, but we will continue to push until we get something more than that. Now, the Nigerian Association of Nephrology has also recently inaugurated an AKI guideline committee, and I happen to be the secretary of that committee because, like we mentioned, there is paucity of data. So we are trying to update our registries and also get a guideline that will help people, not necessarily nephrologists, even the general practitioners, to be able to know the first things they can do for a patient who has AKI, and also to help early diagnosis of AKI. Infrastructure development is very, very important. Like we said, you need to, part of the stop AKI is to be able to diagnose and treat the causes of AKI, and you need to do this in a good setting. However, if the government goes ahead to build health centers in rural areas and there are no people to man them, there's going to be a big problem because right now in Nigeria, we have what we call the JAPA syndrome. The JAPA syndrome is exodus of medical professionals, especially doctors, to developed wards for many reasons: poor remuneration, insecurity, poor working condition, and the rest of them. So even if you have hospitals erected here and there, dialysis centers erected here and there, when you do not have people to man them, it's going to be a big problem. So we are hoping that the government will step up their game and be able to curb this ugly trend. Now, the role of public enlightenment cannot be overemphasized. Valerie has already mentioned it, and we are doing that. And we are trying to make sure that we don't do it only during World Kidney Days. We go to churches, hospitals, everywhere we can find people, marketplaces to talk to people, not just on World Kidney Day, because we know that prevention is always better than cure. It is cheaper and it's better for us. And we also remind our mothers that for now, we are in April, very soon we'll be having a lot of gastroenteritis occurring, the need for adequate fluid intake, OROS used in their children, and of course, to stay away from the toxin. And like I said, the obstetric causes cannot be overemphasized. The need for good antenatal care is there. So we hope that the government will step up our economic situations, that people soon will be able to afford their care, go to the right place, get the right help, and be able to prevent acute kidney injury from actually occurring.
Thank you, Ugochi. I can see the great passion in your eyes, and also can understand that Nigerian Society of Nephrology has to walk for miles before they sleep. So with that, we move to Manjusha. Manjusha,
Thank
you
you.
please
Thank you.
get in.
Yeah.
And
Thank you. Yeah, sure. Thank you so much. Thank you, Goche. It was really inspiring seeing you speak so much about the development of nephrology in Nigeria. The passion that you have spoken truly is appreciable. So anyway, I have to move on. So we shift our gaze to Indian scenario again, but keeping the platform on to AKI. But before I go to Dr. Urmila, I take this opportunity and we're extremely delighted on behalf of India to have Dr. Ifeoma Ulazi, who has joined us as panelist. She is Deputy Chair of Advocacy and Professor of Medicine, University of Nigeria. She is here. Madam, we are glad to have you here on the platform. Also, we have Dr. Gloria Ashton-Tang, who has joined us as one of the panelists. Welcome you, Madam. Welcome, Dr. Gloria. She is past President of AFRAN and Deputy Chair of ISN African Regional Board. We have also welcomed Dr. Sarala Naikar. Thank you. Thank you so much. We're extremely delighted to have you in the panel. We see Dr. Sarala Naikar also in the attendees. I have requested her to be promoted as panelist. Madam, can you please get promoted as the panelist? We are glad to have all three of you on the panel. We'll come back to you for the pertinent questions in the area of interest of prevention of CKD, AKI, and the dialysis services. Now, my question is to Dr. Urmila, who is joining us from Switzerland. Madam Dr. Urmila, you work in a private sector in Indian perspective. Can you tell us, Ugochi has told so much about the AKI in a public sector. Can you tell us something about the AKI perspective? What are the causes and how do you follow up the AKI patients in a private sector hospital wherein you have been working? Over to Dr. Urmila.
First of all, thank you, Manjusha and the Women in Nephrology India team for this excellent initiative. And I'm really glad to have colleagues from all over the world who have taken time at odd hours to be with us and sort of share their experiences. As Manjusha says, I work in a private hospital, which actually means that you take care of patients who can pay. And that tells you in a way that's saying that you're economically better. And hence your AKI narrative or AKI epidemiology is different. That is actually not true because whatever you do, if it's a community acquired AKI, which comes to us first, the etiology, the presentation, the clinical outcome is the same like any other government hospital. We still see community acquired AKIs because of infections. Infections can be directly related, like infections of malaria, dengue, leptospira, or you have infection-related GNs presenting with really some very bad AKIs, hemodialysis dependent. So that said, we actually get patients who have been seen in the community, treated, and come to us when they are in a very critical state, when they need a lot of support systems. Now, I was going through Oguchi's statement that they are campaigning against lack of or the expensive cost of antibiotics. Sometimes I really envy you, Oguchi, because in our patients, when we get AKIs, they are being treated with sometimes 6 or 7 types of antibiotics. Recently, we had 2 kids who were infantile AKI. That child had 16 antibiotics. Not just 16, that child had vancomycin, teicoplanin, had ceftazidime, meropenem. Somebody even thought meropenem doesn't work, so let's add imipenem. And all that we did to the child was withdraw all the antibiotics. So the AKI that we see in private practice, unfortunately in India, in a tertiary care, is a mismatch of AKI. So that brings into our slogan this time that appropriate use of medicine. It just does not mean that we have to treat our hypertensives and diabetics properly. It also tells us that we don't expose patients with drugs just because we have it, so let's give it. So that's a problem with our AKI. I think, Manjusha, it sort of answers your basic
Yeah,
question.
thanks, madam. Thank you. I completely agree with you that it's a little different scenario in the private sector compared to the public sectors. Now we move on to the other area of the kidney problems, kidney diseases as a CKD. Now I request Dr. Vivian to unmute herself to answer my next question. Vivian, over to you. Brazil ranks third in the number of patients undergoing dialysis. With the increase in number of the ESRD patients, how do you look at the prospects or at the practice patterns of dialysis? What are the dialysis facilities that are available in Brazil, and how do you counter the increasing demand of the patients of ESRD? Over to you, Vivin.
Yeah, thank you, Smajusha. So as you mentioned, Brazil has a lot of patients undergoing dialysis nowadays, and it has been growing year by year. We have something around almost 900 dialysis units in the entire country. Most of them are located in Southeast region. That is the most developed area in our country as well. And dialysis here in Brazil is funded by the government for everyone. So if patients need dialysis, whatever they choose for hemodialysis or peritoneal dialysis, or if they are candidates to receive a kidney transplant, they also are covered by the government. But as you know already, Brazil is a huge country. So as I mentioned, almost half of dialysis units are located in Southeast. So there are a lot of regions in the country that it's a quite challenge to get dialysis or even more kidney transplantation. But people have access to that, which is a little different from the perspective that we have heard until now from the other countries, right? I still think one of the most huge challenges that we have here is also early diagnosis of CKD and AKI as well, because we have like this huge lack of information, especially in the primary care centers and where the prevention has to be done, right? So we have a lot of patients crashing in the ERs over here as well in the other countries, with even not knowing that they have kidney disease. So because of that, they don't receive the proper treatment. And most common causes here for CKD is hypertension and diabetes. And although we have the access, once the country is huge, sometimes the physical distance that the patient have to go to undertake their treatment is also quite challenging, you know. Because of that, we really try to improve peritoneal dialysis penetrancy here in Brazil, but it has been a challenge as well due to mainly financial difficulties that we have, because it's not a therapy that is very well paid. I would say, you know, for the providers, the dialysis providers, it pays less, and also the challenges to deliver the supplies in some regions in Brazil is also very huge, you know, these challenges. Because of that, like we have less than, in the last census, we have less than 4% of patients undergoing peritoneal dialysis in the country, which is like very sad, because for sure we will be able to cover more people with that therapy. So more than 85% of countries receive hemodialysis. And we also have some patients that have insurances that can receive their treatment by the insurance coverage, but most people have the treatment receive the treatment paid by the government. So answering your question, we have access here. It's not a huge problem to that, but I think we still are missing a lot of patients, you know, in terms of diagnosis and strategies to prevent CKD progression, etc.
So it's completely funded by the government. I mean, the private sector is less, and out-of-pocket expenditure for the dialysis is pretty less in Brazil. That's great to know, Vivian. I'll come back to you for the subsequent question. So moving on, we have Dr. Anes, who has joined us from Peru. Anes, this question is to you. Anes, I hope you are ready. You can unmute yourself, Anes. So yeah. So Peru being a middle income country, it has both public and private funding services of the kidney care, which apparently are reported to be inadequate. In fact, that's from the publication of one of yours from your country. So in a recent publication 2023, apart from this, many barriers have been observed for AKI care as well. So can you throw some light on what exactly are the barriers in receiving or in accessibility to the AKI care services in the country of Peru? Over to you, Ines.
Thank you. Good evening, everyone. First of all, it's an honor to be able to share with you here. I appreciate the invitation by the Win India with the spectacular energy to achieve events that important like this. About the first question, the barriers to acute kidney injury care that prevent the included many factors, such as the factors related to the doctors, such as availability, knowledge, attitude, and unfortunately, in the aspect of the general physicians, no nephrologist is pretty poor to lives clearly prevent situations for management, such as severe dehydration or fear to increase the volumes of the patient. As well as use of nephrotoxic medication or even medication cannot be adjusted to a corresponding glomerular filtration rates. Other factors relate to the patient, such as attitude and predisposition to receive the medicine or the prescribed at the different healthcare center. Other factors is the availability of the nephrologists. Since our country, we don't have a population coverage by specialists. We are a population of the 22.7 million Peruvians, and only 28% have a type of health insurance with a presence of a nephrologist. Also, adding the economic and the geographical barrier, since the shortage of specialists make this gap more notorious problem in the impact in the large number of patients with acute kidney injury or otherwise chronic kidney disease, which could be at time completely avoided. Other factors in our country doesn't have a clear healthcare policies, and that included a kidney disease. That is why the process that should be carried out routinely end up being endless paperwork and the long appointment and the waste time for the patient avoids a prompt recovery of the same. Another the most serious problem in the self-medication and the free sales medication in the pharmacies. The population has a great problem reflected since indiscriminate sale result in a large number of kidney injuries, and it is estimated that 80% of the Peruvians has fallen into the self-medication, and the same point, in the same point of their life, and 48% of this have it as a regular practice. And as I mentioned, there are not some clear regulation policies allowed the practice to be kept. And we have also currently we have been working on very intense at the level of Peruvian Nephrology Society, including doctors of the different specialties and doing training on kidney health in the many healthcare sectors. And we have also adopted a very tall stance with our political representative to enter a kidney health policy as a national priority. The support and an excellent work on the Peruvian Society of Nephrology with all his members and the support to the Medical College of Peru has already managed to train 38% of the graduate doctors for rural work so far in the period 2023 to 2024, and the goal is to research is 100% by September.
Thank you, Anis. Thank you so much. I mean, there's a lot of work that's been going on in Peru. I mean, as you have told us, and of course, and trying to give an equity care and an accessible care to everyone is definitely challenging. Thank you so much, Anis. I'll come back to you. So before we move to the second round, may I take this opportunity to ask or to request Dr. Ifeoma, who has joined us. Her interests have been in cardiometabolic disease, CKD's prevention. So Dr. Ifeoma, if you can unmute yourself and also on your video, may I request you to enlighten us on the CKD prevention and the therapeutic aspects, of course, the challenges that you have been seeing in the country of Nigeria. And also you have held various positions on behalf of International Society of Nephrology projects such as COMGAN and all this. And can you just enlighten us? Thank you for joining us, Dr. Ifeoma. Thank you. Over to you. You can unmute and you can start answering. Over to you.
Thank you very much. I just want to congratulate Win India for this. A lot of conversations, very interesting conversations going on. As regards CKD in Nigeria, I've always been the one for prevention. I heard Manisha talking about prevention. I was very happy about that. Prevention is key for us. There's no way we can afford renal replacement therapy, dialysis, transplant, we can't afford it. So if our government can put their minds down to put in preventive measures, simple preventive measures. In Nigeria, things as simple as potable water is not there. So you see children having acute renal failure or gastroenteritis because you cannot get potable water. Infections are rife. People get all sorts of infections. Yes, when malaria is being controlled, but it's not quite there because we still have our children having malaria. Even adults, all sorts of infections. Most of our cases are actually CGN. They come from glomerulonephritis. But the only thing is that because they present late, you're not able to say if it's glomerulonephritis or hypertension. Because by the time they come to you, they have hypertension, they are fluid overloaded and all that. So you're not able to distinguish which is which. So for me, key thing is prevention. Yes, we're going to take care of those that have it already. A lot more people will get it if we don't do much. And we know that in sub-Saharan Africa, we've all heard about APOL1, what is going on with APOL1 kidney disease, that basically people from West Africa have high prevalence of APOL1 kidney disease because many of us have the double allele. And people from my ethnic group indeed have the highest. So it is important we set in prevention. And you don't get APOL1 kidney disease unless you get the second or third hit. So if we can prevent all those risk factors that cause kidney disease, we'll go a long way. And Nigeria also, metabolic diseases are there, but not as much as it is a problem in India or the Western world. Our key problem here are infections, hypertension, because the very makeup of the Black person is not to tolerate hypertension. When they have hypertension, it is worse. When they have diabetes, it is worse in them. And they have, when they develop chronic kidney disease, they develop it early too. So you see young people as young as 30, 40, having chronic kidney disease. What do you think that does to our economy? Our economy is basically finished because the young people that should grow the economy are dying. And the other thing I want to say is that our government is not doing much. We cannot achieve much in sub-Saharan Africa if we don't get our governments to get involved. People are basically poor. Ugochi has said so much about the poverty that is rife in Nigeria now. Nobody can afford anything. I think a sachet of Augmentin is as much as, is it 150,000 is about, what would I say, about $100 or $50. That's how somebody who earns maybe 30,000 has to buy a card of Augmentin, earns 30,000 a month, has to buy a card of Augmentin for 50,000. Where does he or she get the money? Where does he get the money? So my take is that we need the help of everybody. in sub-Saharan Africa. From the international organizations, each time I speak about this, I'm calling on the international organizations. I'm also calling on WHO. Let's say it as it is. Let us say it as it is to these governments. I know that, well, we have to use advocacy, use mild terms and all that to get them to go around. So I'm maybe talking out of passion and all that because I know what is going on. And I feel we need to do a lot more in Nigeria. Come to transplant. If you look at our transplant National Act on healthcare, you look, transplant has, I think, a page in the National Act. And look at what they said about if you happen to buy a kidney, you pay $1 million. $1 million is like $1,000. I mean, what does it mean to anybody? It doesn't mean anything to most of the people that can afford to buy the kidney. So, I mean, we need to do a whole lot more. Let me not just continue boring you guys about what is happening in Nigeria. But I guess I live in Nigeria, I work in Nigeria, I'm a Nigerian, so I'm bothered about that. And I think also that similar things go on in different sub-Saharan countries, maybe at different stages and at different extents. So thank you very much for allowing me to speak.
Thank you. Thank you so much, Dr. Ifeoma. Thank you for sharing the experience and what exactly is going on in Nigeria and what are the preventable causes. Over to Dr. Valerie and Wumila. Both of them have raised their hand. Any question to be asked to Dr. Ifeoma? Over to you to unmute yourself. Okay, right. It was this thing, incorrect one. So I move on to another great nephrologist who has joined us, Dr. Gloria, who is here. May I request you to unmute yourself and also video on for the next question. So Dr. Gloria, you also have been holding good positions from the International Society of Nephrology as well. You have done a good work in kidney services. Can you share your experience on the prevention of CKD as well as addressing the AKI in sub-Saharan Africa as well as the global community? Over to you, Gloria.
Thank you very much. And I want to say this is a fantastic session. In terms of chronic kidney disease in Cameroon, for example, I can say we've done a little bit. We've done something, but unfortunately, the government, I think, understood it the other way around, because right now we are having dialysis units all over the country. We have even 3 government units in some towns. And dialysis is also highly subsidized. So patients pay about $30 US per year to be on dialysis. But the problem is, this is for dialysis. All the other things, anemia, calcium, bone disease, and all that hypertension is not taken care of. And nothing happens to CKD before dialysis. So that is why sometimes I say, I think I passed on the message wrongly. So that is, as CKD is concerned, you would say, if you ask anybody in Cameroon, they say, oh, we know CKD now, but we need prevention. We need the general practitioner to be able to pick up patients at risk and do the things he's supposed to do. We also need them to be able to pick up CKD early and send, because right now, about 80% or even 90% of patients see the nephrologist always in stage 5 of CKD. So I think we kind of failed somewhere along the line. Now, in terms of acute kidney injury, there's still a lot of acute kidney injury. And most of it, we don't know the cause. So we are suspecting that we have some toxic mechanisms going on. Recently, we just discovered there is a syrup that is being sold around for $50. It treats everything. It makes you fine and all that. We had 3 patients with acute kidney injury from it. And we just had, last year too, we had 10 children who died from acute kidney injury from a syrup too. So, of course, we still have obstetrical causes, eclampsia, preeclampsia, hemorrhage, and all that. But these are just, if I may summarize, the problems we face. Now, transplantation has started in Cameroon. We've already had about 10 transplant patients. We'll be transplanting again soon in May. Now, for the transplantation, again, it is all free of charge by the hospital that does the transplantation, not the government. I think the government plans to step in, which is a good thing. But we don't know for how long that would last. So those are some of the issues we are going through now, because we need to know, because they shouldn't get up one day and say, oh, we don't have any more money, and then these patients will not be able to pay. So in a nutshell, that is the picture of Cameroon. Thank you.
Thank you so much, Dr. Gloria. It's been really enlightening to know about the kidney services and, of course, the development and going up to the kidney transplantation, as you have just told us. Thank you so much. And we are indeed enlightened to know about the, the trends and the development of services that's going on in the country. So moving on, we have Dr. Sarala Naik, who has also joined us, who has also posted a question in the chat box. May I request Dr. Sarala, madam, to unmute yourself and then also video on and speak to us, since you have so much of an experience in the field of nephrology. You are one of the doyens in the field of nephrology. Can you tell us the how the nephrology has changed, the practice patterns have changed over a period of time, and of course, how do you foresee the development of nephrology across the global community? And do you look at that we need to focus on the preventive strategies more than the therapeutic aspects? Over to Dr. Sarala Naikar. Madam, if you can unmute yourself, Dr. Sarala Naikar.
Hello.
Yeah.
Can you hear me?
Yes. Glad to see you. Yes, yes.
Correct.
Over to you.
Yeah. Firstly, to congratulate Win India and all the panelists for this wonderful webinar. I've really been listening with great interest to all the comments, which I think are common, all have a common theme. And also what Gloria said really resonated with me. I must say, after all these years devoting myself to developing technology, developing PD services, hemo services, transplant services, I realized that I haven't really succeeded where it really should be done, which is prevention. So that is something that I have a great regret about. And I think perhaps all of you are still active in the field should perhaps focus on giving more time to prevention. I think the thing about South Africa is that, there are patches. We have patches of excellence where you can do anything, the highest level of technology. And there are whole areas which have no services at all. We have areas where we don't have water, we don't have electricity, and that's also moving into the city. So we're really a sort of microcosm of underdeveloped and highly developed country. And so we have a lot of metabolic problems, diabetes, hypertension, and also a lot of infections, including HIV. So I think our government is struggling to provide services, appropriate services. When we had a renal summit a few years ago, the government really wants to focus on prevention, which we thought was great. They weren't going to put in a lot of resources for kidney replacement therapies, but we thought, let's start with prevention. And there were a whole network of primary health clinics, but unfortunately, they're also becoming dysfunctional in that basic drugs for hypertension, for TB, for HIV, always stockouts. So it's a huge issue. And one of the big things that South Africa is trying to embark on is universal health coverage. So while there's a lot of enthusiasm for it, there's also a lot of trepidation, because is it going to be well run? If we've had really functional health systems collapsing, can we now set out to have a really well run national health service for all levels of healthcare? And we hope there that we would have good prevention programs. So I think just to tell you my feelings about where we are going in South Africa per se, we've had all levels of transplantation for various organs going on the one hand, and on the other hand, you'd be doing your renal clinic and you'd find somebody who's had diabetes for 15 years suddenly coming in stage 5 CKD and has never had a creatinine until the one that was done, which alerted somebody, and that person gets sent to a nephrologist. So we have these pockets where high-risk people like the diabetics, the hypertensives, who are attending clinics or attending their healthcare practitioners aren't being assessed. They aren't being screened for kidney disease. So we really need to sharpen and refocus our message as to what should be done. And I think that is a universal problem. And one of the things that we're looking at would point of care diagnostics help. Unfortunately, they're fairly expensive at the moment, but it might help if the clinician can see a patient or any healthcare worker screening can immediately pick up people who need further attention. So I think the other area that we really need to focus on is a lot of people are very intimidated by nephrology and kidney disease. So I think we need to actually demystify it and really start teaching medical students the basics so that they are comfortable with kidney disease. They seem to be comfortable with cardiac disease, so we should make them equally comfortable with kidney disease. Thank you very much for inviting me to say a few words.
Thank you, Dr. Silanaika, for joining us. Definitely, the point of care diagnostics is upcoming, and of course, we need to look into the cost effectiveness of utilization of the point of care diagnostics, which presently is not so cost effective. But then I think we need to look into that, and certain guidelines are also going to come. Thank you so much for joining us. I think we are done with the beautiful round of questions. If anybody has any other comments to be done, because we are little 70 minutes since the start of our session. So we would like to come to the end of this session, and we would like to thank everyone for joining us, the senior women nephrologists, global leaders in the field of nephrology who have joined us again, have shared their experience and have given lots of insights into the ongoing nephrology therapeutic aspects, as well as the prevention, as well as the future aspects. Thank you so much for joining on today's session. And I would like to hand over to the host, Dr. Jyoti Priya, for closing the session. Before that, anybody has any comments to be made? Probably a quick and short comment can be taken. Yes,
Manjusha, I
yes.
would like to take a short comment of Dr. Valeri on the conservative kidney care before we come to an end, because this is another very pertinent area which has been raised. We discussed about CKD prevention, about dialysis care, to some extent about the transplant as well. This part of the CKD care remained relatively untouched, and I feel that this is an evolving area because of increased life expectancy of our patient population. Because of age, they grow into CKD, and that CKD is worse on platform. Valerie, a very short comment from you.
Yeah, thank you. I'm not, I'm sure everybody else here has as much experience as I have with this. I think in the higher income settings, it's almost a luxury, that elderly patients get to choose whether they want to go on dialysis or actually in some cases have a better quality of life, even if it may be slightly shorter or sometimes not even shorter without dialysis, but with the confidence that they are going to be supported throughout this whole process. They come to clinic, they have blood tests, they have, people are bringing them food and, being driven to clinics and whatever. I think one of the challenges, and I've definitely discussed this with, Ifeoma and with Gloria and a lot of other people on this call, is what happens to the people who present with end-stage kidney disease in countries where they cannot pay out of pocket for dialysis. And there, I really do think that part of, standard of care should really be providing support. I know in Cape Town, for example, working quite closely with Red Cross Hospital with the children, they screen the children for transplant eligibility because they've had bad experiences that certain children who come from really very, very poor environments just get extremely sick, get terrible infections, get severe rejections, and lose their kidneys. So they have developed a screening process, but every child that doesn't get onto the transplant program is given palliative care. They have a pediatric palliative care special service, and these children are really, at least hopefully, managed as well as possible, sometimes using distance, but they have satellite nurses and things. And so I'm thinking what Manjusha was mentioning about the hub and spoke should also expand to palliative care. I'm not sure in India, but I think in a lot of other settings. But maybe Gloria, or if you might have something to say, because I think one of the challenges, I was just speaking to a lady from Nepal who is a palliative care specialist working with the refugee population in Cox's Bazar, etc. They cannot get morphine, for example. And in our patients, we need rather hydromorphone than morphine because of all the complications and the side effects, So I think we also need to have a say in the essential medication that's required to provide palliative care, especially end of life. When somebody's very short of breath, we need to make sure we have the right medication to help them to be comfortable and show the families that the health system is still caring for the person, not just dropping them on the side of the road. Because I really feel that there's this dignity that we need to try to help every single patient preserve their dignity. And I often feel the humiliation of having to leave the hospital acknowledging you can't pay must be overwhelming, So I think if Yoma, maybe you can say more than me or Gloria or anyone else, maybe Viviane also has something to say, or Anis from your settings.
Yes, thank you, Valerie.
Yeah.
You have said
Gloria.
quite a bit. Yes.
Yeah.
Can I go on? Okay.
Yeah, great.
Okay. So it's obvious that in countries in sub-Saharan Africa, like we all know, it's out-of-pocket payment. And when it's out-of-pocket payment, about 70% of your population is living below the poverty line. You can imagine what goes on. And it's within that 70% that you get most people that have chronic kidney disease, most people that need the dialysis, most people that need the transplant, and they never get it. So it's like they just die. The first few years when I started nephrology, I used to be so sad because a patient you see today, tomorrow you don't see person no more because the person dies. They used to die so much. It was very, very depressing those days. So the point, that's why I keep saying we need to get our governments to do something. This is not something anybody does for you, it's the government. What is happening in Cameroon is an example. All they need to do is now to embrace prevention. Have it all in a package, like they have, I think it's in Thailand or Taiwan, they have a package of prevention to dialysis and all that, everything comprehensive. That's what we need to look at. Even if it's the minimum we can do, the minimum, nobody is saying to go overboard, the minimum we can do to help patients and to help the healthy ones not get kidney disease and those who have it not progress to end-stage kidney disease. Provide the drugs, if we can get the drugs provided like they were doing for HIV or for TB or for, HIV and TB, where they get their drugs almost very cheap. That would help. That would definitely help. Yes. Thank you so much. I think I'll stop so far so that others can add their own comments.
I just wanted to add
Great input.
And Valerie, because in the Caribbean, there is a Caribbean Palliative Care Association because we recognize the need that conservative management in kidney care and advanced kidney disease it's a real issue, and we don't have enough resources. And part of it is cultural as well, because when you approach a patient, they can't afford dialysis. We have a finite amount of numbers of public dialysis machines, hemodialysis. So we just cannot support those who need it. And so the conversation comes up of advanced care and, I want to not use the word palliative dialysis, but, supportive care. for these patients. And it's a difficult conversation because many times many of the families have exhausted their bank accounts trying to supplement, because we can only sometimes offer 1 to 2 sessions per week of hemodialysis in the public sector in Jamaica. So it's very difficult, and they're trying to supplement for a 3rd session or just the other supportive medications. So, conservative care is definitely something that I need to learn more about, and, our colleagues as well, to have those difficult conversations.
Thank you. Thank you, Dr. Raquel. Thank you so much. All pertinent
Thank you
points
for your input.
session.
Yeah.
Yeah, thank
So,
you so much,
Manjusha,
Dr.
we have come to the end of a
Yes.
session.
Yeah, thank you, madam. Thank you
Yeah,
so much.
today's session. Yeah,
Thank
yeah.
you. Thank you, everyone, for joining us. It's been
Thank
amazing,
you,
and we
everyone.
are extremely
Yes.
delighted to have everyone who have joined from across the countries. It's been indeed an extraordinary support from all the global leaders for joining us today on this platform and sharing your experience, which in fact is priceless for us. Sharing your insight, sharing your experience, and also empowering each other is the crucial principle of what we are looking into, and exchange of the knowledge as well. So thank you so much, everyone, for joining us. And now we come to the end of the session. I request Dr. Jyoti Priya to close the session, who is the host of the program. Over to Dr. Jyoti Priya.
Thank you. We have come to the end of the session, had Madam rightly mentioned. It was truly remarkable, insightful, and brilliant panel discussion we had. It was exactly like a global platform, so inspiring, and the collaborative effort was so much highlighted. Thank you once again. Thank you, panelists and all the moderators. And once again, thanking all the attendees for being with us till now. And looking forward to meeting you tomorrow for the exciting quiz competition. Thank you and good night.
Thank you all again on
Thanks so
behalf
much.
of.
Bye, everyone. Well done. Well done.
Thank you
Bye,
so
bye,
much.
bye. Congratulations.
Bye, everybody. Bye-bye.
Bye. Take care. Bye. Good night. Bye.
Bye now. Bye.
Good night. Good night. Not to everybody.
Oh, yeah. Sorry.